as a physician, like just as a practicing clinician yourself, what are some of the things that when you see a patient for the first time, what do you have to do in your head as a clinician when it comes to like that topic of bedside manner?
I think one of the important things that I think has evolved is the idea that what I'm trying to build as quickly as possible is trust, right? The patient is going to walk in and they've already had an initial exposure to care by your practice based on their experience setting up the appointment, finding your office, what was their interaction like with the front desk staff. So a couple of things have already happened by the time they get into the room and you walk in. And very quickly, I want to establish not only that I am somebody that they can trust, but somebody that has their best interest at heart. For me, in my current practice, the vast majority of my patients are Spanish speaking. So as soon as I open my mouth, even though they can't see it, because I've got my mask on, they tend to perk up because I'm speaking to them in their language. And that's an immediate kind of response that is very human and something that I think goes a long way. Typically, many of these people have been to a number of different physicians and have often had to work through a translator. Many of them will say, "Oh, thank God you speak Spanish," or it's so nice to be able to express myself in my own language. So I think that's one of the first things is really establishing that trust, and then being a good listener, I think, is the next part and key to the bedside manner. Just taking in the information, looking people in the eye, and really listening. And this is a challenge, especially in an environment where you have the pressure of time. And very often, depending on your setup, you may or may not have your computer in the room and might be clicking and typing while you're doing it. So it is important that you are conveying with as many nonverbal cues as possible that you are listening to that person and asking the questions, seeking clarifications. I think another good practice is often repeating back to the patient or their family, here's what I understand. And then for the sake of speed, I often may combine my questions while I'm actually examining the patient so that you're kind of gathering the information about the history and simultaneously conducting your exam. And then I think towards the end, when I give them my impression and then my plan, I have created a number of handouts, both in English and in Spanish, for patients. And I spend some time explaining either my logic or just some instructions on here's what you need to do, here's how you're going to do it. And that's reinforced by the literature that I provide. But it is important, and it's to be sensitive to the fact that there are a lot of patients, and certainly in the population that I serve, that may not be able to read. My clue is if they've been handed a form ahead of time to fill out and it comes to me empty, most likely it's because they can't read it. And so I think that that's something to also be sensitive to. And I do very often explain using pictures. So if I have a patient that has reflux, I have a handful of drawings that I have memorized and just will whip out and explain to them, here's your stomach, here's your airway, here's your esophagus, here's how acid is supposed to stay in the stomach, here's what happens when it doesn't. And so this is all an effort to transfer as much of my own education to the patient in a way that I'm gauging they're able to understand, in the hopes that being armed with a little bit of information, they are more likely to follow through with my recommendations. So I think, yeah, trust, listening, and education for me are kind of keys to a good patient encounter. Yeah.
Well, and when you talk about the resources you provide, or I guess, are you listening to someone with a stethoscope and you're like, uh-huh, uh-huh, and then like you're
So
kind of doing that?
yeah, good question. Because I really focus from here up, don't use a stethoscope. So I'm usually looking in their ears, looking in their nose, looking in their mouth. I don't have high expectations for cogent responses. Therefore, don't ask questions while I'm looking in their mouth. But yeah, sometimes you do have to combine things, and sometimes if I know that there's a finding or something that I don't want to forget, or oftentimes for myself, I need to draw something out, I will just turn to a piece of paper and scribble something down. And particularly if there's a finding in the ear that I don't want to forget, or some other comment I want to make sure that I don't miss. One of the other interesting opportunities is when I see kids, you can have a mix in terms of the parental attitudes or success in continuing their native language, right? So there are some families who will choose not to pass along their language. And I think that this was often in the early 1900s with the big waves of immigrants through the US to the US through like Ellis Island. People who came from Italy and many other countries, people did not want to continue their native languages because they felt that the most important thing was to assimilate as quickly as possible, and that learning English was the most important thing, and that the flip side to that was not holding on to your language. And so you had many people whose parents may have spoken the language and they may have heard it a lot at home, but didn't necessarily learn it. When I'm seeing patients, especially if I have kids, I will always ask the kid, do you want me to speak to you in English or in Spanish? Because I want to make sure that they're comfortable. Again, going back to the first thing I need to do is establish trust. If I can't do that, then it's going to be much, much harder for me to obtain information, honest information, accurate information, and then for them to even follow recommendations if they don't trust me. And I very often will comment, especially if I know that they speak both languages, that's great, and to keep it up, because I know as a kid for myself, it was, you want to be just like all your friends, right? And it can be hard, and it's oftentimes a fight to speak while you're learning, English. You may be embarrassed by the fact that you speak another language at home, but I really like to reinforce to the kids to keep it up. I reinforce it to the parents of, that's an awesome gift that you're giving them, it's it's often a source of such kind of so many battles for a parent. It's easy to second guess and be like, is this worth it? Am I hurting my kid by introducing another language? Is it going to confuse them? When in fact, I mean, it's been shown that it's a huge advantage. I mean, I think that's just another thing that as a parent, as somebody who has been a kid, I can relate to the kid as a parent now, and someone who wants to be able to pass along another language to my own kids. I know that it's difficult. So again, empathizing with the situation, that's also something that I bring into that conversation with the family and with patients when it makes sense. So.
Yeah. Do you feel like when you wear certain clothing too, like when you're engaging with patients in the clinical setting, does the mask and the lab coat, does that kind of throw people off a little bit? Or are they like, well, you're a doctor, so of course you're gonna wear something white. What does that do in that situation? Do you ever feel like that's a difference maker or not really?
It's the only thing I've ever known, and it's the only thing I've ever seen. I have not run into a situation where it seemed distract. I think that's very much kind of the uniform that people have come to expect. So, for example, I think to see a plainclothes policeman, I think is far more shocking than to see a policeman in uniform, right?
Mm.
So there are expectations that come with the outfit. I think it's perhaps what was stranger was when I was doing my fellowship in facial plastic surgery, and then when I went on to practice, I would wear a suit just because that was how we dressed for my fellowship. That was how my director dressed, and there was a big emphasis placed on that type of formality as distinct from wearing a white lab coat, which tended to be associated with you being in a place where you're sick and we're trying to make you better. The whole kind of context, especially in cosmetic surgery, is a very different one. It's more around, you know, looking your best. So with that comes this concept of, well, you're going to dress your best kind of in that environment. And this is all about a certain image, and everything is clean and tidy and high end, this and that, right? Because it's part of the image that is being portrayed. And very often people are there because they want to enhance their appearance. So again, the uniform there is a different one than often you might see in a hospital. That being said, depending on if somebody is jumping in and out of procedures and stuff, they may just be wearing scrubs. So I think, you know, that has evolved and that has changed. But to answer your question, I have not interpreted that my wearing either scrubs or wearing the white coat was unexpected for the patient or anything.
Yeah. I'm just curious how it affects kids. I have 4 kids, and like when they see a difference in their environment, like, oh, this is a special person because they're wearing something different. My red flag goes up, or my alertness, increases in some way.
To that end, Alex, there is something that is dubbed white coat syndrome, and it is based on an association of that white coat with, for example, a needle or with something that's going to result in pain. And so there are actually a lot of people who, when they go see their doctor, they're anxious. And so they naturally will get their blood pressure readings are always high when they go to the doctors, but they'll swear, man, when I take it at home, when I'm elsewhere, it's different. And again, that's one of the reasons why it's actually very valuable to have not only the patient record information outside of the hospital, so you have something to compare it to, but also to bring their device in every now and then so that you can compare it and make sure that it's not just that you're getting major differences in the readings with two instruments on the same physiological, condition. But yeah, sometimes kids will associate that white coat and start crying immediately, especially the very, very little ones, especially ears. Kids hate having their ears checked. And
Yeah.
if you're a little kid and have had a lot of ear infections, right, it already hurts, and you're going to a doctor, and as soon as that white coat comes in, you know that what comes next is I'm going to have to sit on mom or dad's lap, and they're going to have to hold me down, which I don't like, so that the doctor can look in my ear, which already hurts. And I'm going to shake my head while somebody's trying to hold it. And no matter how hard they try to hold my head, I'm still going to move, and that speculum's in my ear, and that's going to make it hurt. Right. So I guess going back to your original question, the answer would be, to little kids, yes, the white coat is something that's is far more likely to spark a sense of fear or trepidation, typically based on on prior experiences. So what I often do in those situations is I either do an Elmo imitation, or I'll tell the kid that I'm looking for a little bird in their ear, and then I can either do a pigeon noise or tweet like a little baby chicken, and that oftentimes will kind of startle them enough for them to stay still for a second. But so you just kind of learn tricks.
Yeah, so that's like your trick of bedside manner in a way, like how you're doing that with the
Yeah.
child. Your unique way to connect is making the Elmo sounds, making the little chirping sounds and things like that. So
Yeah.
that's really cool. Did they cover this topic of patient engagement, bedside manner in this way where it's like, the social emotional situation that you're in? How do you consider that? That's the first question. Were you taught that, or was that ever emphasized or discussed? And then two, other medical specialties and medical peers that you have, do they talk about this? Is this a topic of conversation that comes up between them?
Traditionally, and this may have evolved since I was in medical school, historically, the first 2 years are classroom, and the second 2 years tend to be spent in the wards, as they say, or in clinic, where you get kind of rotations. There are attempts to talk about not only bedside manner as kind of a academic topic and do's and don'ts, there are also attempts to teach and formalize discussion around cultural sensitivity and diversity. We had a humanities class that was required with required reading and associated tests and exercises, again, with the goal of reminding people that what you're examining is not just a body part, but it's an entire human with feelings, passions, concerns, because you very, very quickly lose that in medical school. Perhaps the most impactful learning is in the second 2 years when you're on your rotations, where you learn from your attendings and from the residents as you're rounding, and you're just, because you're worried about, okay, am I going to gather all the information, right? You're really concerned about the mechanics, and that's ultimately kind of what you're primarily being tested on. There's so much to learn, and you're just focusing on that type of thing. But you do get exposed to people who have great bedside manner and others who don't necessarily have great bedside manner. And then in residency, so now you've graduated medical school and you're a doctor, a lot of your training and a lot of your exposure is with more senior residents. Again, they may or may not have great bedside manner. The most important thing is being fast, because there's so much work that has to be done. And especially, I did, a surgical subspecialty. You got to do all of this stuff before having to go down to the operating room that starts at 7:30. So you have to have completed, having seen all of your patients, written up all of your notes, presented to your team. All of that has to have happened before like 7:15. And depending on how many patients you have, you may have had to arrive at like 4:35 in the morning to the hospital to just begin your day, right? And so there's just so much work, and the emphasis again is speed. It's very hard to sit down and have very meaningful connections with people under extreme time pressures. It just really, you are driven and pushed towards a very transactional encounter. And because you're in a hurry, because you have so many patients, you also have to prioritize. What's the most important thing? Because what is going to hurt you on that day is not having the answers that your attending is going to be expecting of you. The most important thing to them, and therefore to you that day, is going to be, what are these numbers? What are these findings? This and that. They're not going to care about how you made somebody feel unless they end up getting a complaint later on that you did something that resulted in a complaint. Very often, that bedside manner there, you end up having to weigh what you're getting, and speed and time pressures really tend to push people into far more transactional exchanges. And so I think the more we pile on people, the more we expect within a compressed amount of time. It is, again, as I've expressed to you before, no surprise that it's going to have a negative impact on that interaction with people.
Yeah, I think, well, I was reading the book, The Rabbit Effect, how the science of kindness like actually heals people. Like there's research behind like having that just the 2 or 3 minutes of empathy in addition to all those clinical numbers and all the things you're looking for that you have to report on, just taking those extra few minutes actually, resulted in that patient getting better faster, not having to, get readmitted to the hospital later. So you're dealing with just those few pieces of communication that if you were to do that, or if that was taught and trained among physicians as an emphasis versus go faster, do numbers better, I kind of wonder if that would change our healthcare outcomes, or at least a little bit of an impact on better healthcare outcomes. I'm not sure. I mean, I'm not a practicing physician.
Yeah, I think, it could be nice. It's more likely that as opposed to adding 2 minutes to every visit, because now you have to multiply that by the number of patients that you have to
Ooh,
see, and then tell me what time you have to come into the hospital, right? And then if a patient's being woken up at 5 in the morning, I don't, it's just not realistic. So there's that. It's far more likely that in the interaction that the focus is on kind of what you're saying and how you're saying it, as opposed to being able to tack on more time. It's just part of the reality of there are only a certain number of hours in the day, and the way that staffing ratios are set up, you are at the mercy of that. So
and is this what your doctor friends are saying too, and your clinician friends that you've met? This they don't even talk about this because they're focused on other things.
I think at this point, I'm well into my career. Most people are talking about, for example, oh, Medicare just reduced reimbursements by another 2%. Oh, insurance continues to go up, right? It's costing everybody more money, but the reimbursements are going down, inflation's going up. So where's all this money going? That's far more top of mind, at least in my day-to-day, than is a discussion around bedside manner. It's just the reality. Most people are still trying to pump through how many patients can I get through in a day. And also because the more patients that you're able to see, then conceivably the shorter the wait time is for you to see your doctor. If you have somebody who's spending a bunch more time with each of their patient, that means that you as a patient are going to have to wait more days or weeks or months to see that physician, right? So all of these things kind of, it may be nice in the immediate encounter, but when you look at the big picture, you realize that at least that one-to-one solution is not necessarily scalable. And so you start to understand why the processes end up being broken down and different bits are farmed out to different members of the care team. It can't all be the doctor doing everything. For example, a nurse has, in an inpatient setting, has far more face time with a patient than a physician does.
That makes a lot of sense. And then this is where it comes into the case where like maybe the nurse can have a red flag ear for, oh boy, this patient, I need to tell the doctor we should refer him to a psychiatrist. Or like, you have those, maybe they catch a social emotional issue that, wow, this person needs way more empathy that this doctor just doesn't have time to do. I got to get them to another doctor. Like, does that happen sometimes too? Referral type scenarios in that way?
I mean, yes, a nurse, because he or she may have more contact, may have insights into other services that may be of value for the patient. Maybe there's a social worker that they've picked up on that it would make sense to be brought into the mix. And sure, it could conceivably be a psychiatrist in certain situations as well. Yeah.
Have you had to do a lot of referrals to yourself in that way? Like as you've met with patients, you've been like, see something here that I need to get this person over to so and so now.
Yeah, so and I think that especially in the pandemic, there are a lot of stress-related manifestations or manifestations of stress. For example, stress is known to be associated with reflux, and reflux is something that can impact the throat and cause a sensation, I got something stuck in my throat, or my voice is changing, or it's uncomfortable when I swallow. But also, when people are stressed, they're more likely to clench their teeth and bite down, and so they can get temporomandibular joint or TMJ dysfunction. And because the temporomandibular joint is so close to the ear, you'll often see adults who come in and their story is, oh, I've had this horrible pain. I went to the ER. They looked in, they gave me antibiotics, but it's still hurting. It's unusual for adults to get middle ear infections like a little kid. And so in talking to them, you realize that, oh, they've got some major stressors. They're living at home with their, eldest daughter as a result of the pandemic, and they lost somebody, they're the husband, and there's, tensions of being kind of stuck in there. And as you tease this out, you realize that's actually what's going on. And so, yes, I will, in my recommendations that end up going back to the primary care doctor who referred them, I will mention, hey, I think the common denominator here is some anxiety or some real depression. So it's, the flip side or whether or potential advantage of creating trust very quickly is that, yeah, some people will open up very quickly and become tearful, and you suddenly realize that's what's actually going on. Me just handing them, you know, telling them to put warm compresses on this joint, that's a temporary fix because they're going to go right back to that home or that situation or that mindset that's at the root of this problem. So again, I think that that's part of the education and explanation that I try to do. And Alex, one of the things is I probably take significantly longer, or I know I do. I take much longer to see my patients than my colleagues at work do. That's a decision that I made. So I don't make as much as the others do based on the number of patients that I'm seeing. But I think ultimately the real decider is going to be outcomes, right? And how you measure those outcomes. And now we get to another part of the problem is most physicians have no idea what their outcomes are, especially in ambulatory care. You have no idea. Did they not come back because it worked? Did they not come back because they disliked the experience and never want to see you again? Did they not come back because they are currently meeting with a lawyer and are going to file a malpractice suit? Right? There's lots of reasons, and it's rare that a patient's going to come back and say, it worked, everything's great, thanks so much, high five, and then you leave, right? It is because so often you don't have good insight into what happened or whether it worked or not. You might be left wondering. And then at the individual level, but at kind of the global level, it can sometimes be very difficult to say, oh, spending more time with these people, it worked, or it was worth it, as opposed to others, maybe they find, no, all you did was make people wait longer to see you, right? So I think the jury's still out on that front. Lots of things that can be studied there, but I like to think that it's effective. But I mean, to really study it objectively is important. I mean, ultimately for healthcare, it is very important. So.
These are some root issues here that you just mentioned too. Like, well, that one guy with the ear example, if he's dealing with anxiety, well, what if our whole healthcare system is dealing with like that anxiety? What if we deal
Oh,
with
I'm sure it is.
what are
Yeah.
those qualitative outcomes and quantitative outcomes that you can track in the next year or two? Why aren't we tracking that?
Because how do you track it? I think the problem is, so if you think about every time you go to a restaurant or something, people want send you an email. Oh, what was your experience like? Or after this, if every single encounter you have with any sort of business is sending you that stuff, you get you get email fatigue, you get survey fatigue. Like the last thing you want is to have to go do that. I think so it's difficult. It's difficult. And then how do you define success? How far after the visit do you measure it, right? Is it at a week out? Is it 3 months out? Is it 6 months out? Right? So to truly measure the effect, there's a lot of things that need to go into that. And when there isn't a really good agreement on how you define a successful outcome, if you're stumbling with that step, then you are miles away from getting your answers. So oftentimes, it's easy to measure certain things that CMS has prioritized, like, okay, what was kind of the bounce back rate, right? There's oftentimes disagreement that's still ongoing about what is actually measured today, and is it really a proxy for health? I think that definitely there needs to be more of an effort put into gathering patient feedback, right? In terms of, is your quality of life better? Did the doctor satisfactorily solve your problems? I think that the challenge is, as I mentioned, is obtaining that information, right? A lot of websites, like you can imagine here, I'm just going to hand you this iPad right after you walk out of the room. If you're using Wi-Fi, a lot of the survey sites will see that you're sending all of your surveys from the same IP address if you're using the local Wi-Fi. And so they won't count them because they're like, oh, that's just an employee who's just doing the stuff. So it's a lot of hurdles to getting a lot of this information. So
Your thoughts on technology too, like how to use technology in this setting. But I guess you would, before a visit, you'd read the chart notes, then you'd know how to engage with that patient, likely, right? I mean, you're using
yeah,
you
the
have
the challenge is, if they're a new patient, at least all I get is a piece of paper that says, please evaluate and treat the patient. Very often I walk into the room and I don't know why the patient's there. Sometimes the patient doesn't know why they're there. And that's just a failure of, we still have a very broken system. If everybody's on different electronic health records. So if I have a dizzy patient and they went and saw a cardiologist because they had one episode, and they went and saw a neurologist, and now I'm the third doctor they're seeing, I often don't have access to that information when I'm seeing the patient. And so the risk there is that I may end up ordering a test that somebody else is already ordering, right? And so then it becomes a problem for the patient and the insurance company. I didn't know. I didn't have that information. The patient didn't know, but the insurance company, you better believe they're going to know, because they've now been asked to pay, twice for this study. They're going to deny it. Then the patient is stuck having to battle with the company because they didn't know that, they didn't know the doctor didn't know. So they just showed up because they were told to go there and do it. They're just following what somebody told them. So yeah, it's tricky.
yeah.
It's a lot of stuff.
Well, thank you for your time. Wow, you gave me a gold mine of just things to think about and content here to really understand. And you're just helping me because I'm not a trained medical practitioner of any kind. I'm just a digital marketer learning this healthcare space. And I know a lot from the patient side, having chronic condition and things like that with asthma and my history, those things. But still, I want to be able to communicate better to our physicians and our doctor audience, So I just thank you. I'll just say thank you for your time.
My pleasure. My pleasure.